for the kind invitation and for superb organization of MASSIN meeting in Houston. We thanks Professor Samii, who has gave the nucleus and initiation of this society and bringing all the elite Majid Samii scholars to this venue. Am I on? So this is the institution where I'm working in Saudi Arabia for the past 35 years. Inherited that position from Professor Al-Mufti. And this is the place where I've been trying to bring some technology and innovation that I acquired from Professor Samii to my place. There are several codes I felt I learned from Professor Samii and tried to collect them. And yesterday was several comments and appreciation given, and I'm just summarizing. The first code I learned from Professor Samii is simplicity trump complexity. I'm going to give a few examples. And flexibility vanquish rigidity. The best example was the discussion yesterday on the bifrontal approach or lateral approach for the anterior fossa, and giving proof for that. 2006, I organized a meeting, the Asian Congress in Dubai, and 40 superb, experienced skull-based surgeons were invited. You can see Rotens, Vesisol. You see many of them. Bob Spetster was there. Kawazi was there. Just name it. Al-Mufti was there, but he was not in this picture. He has to rush somewhere. And I highlight the two pictures of Professor Samii and his associates, ENT colleague, who initiated the skull-based principle from ENT and neurosurgery. We were discussing all these fancy approaches, the complex approaches. You start from the front to orbitozygomatic, to the combined approach, the Hakuba approach or modified approach, and the so-called far lateral approach. Yeah, I want to keep the picture. You like to see the picture, yeah? This meeting again in Dubai in 2018. Professor Samii was the invited speaker. But to tell you his commitment, he called me from the airport. He has an urgent call he could not attend. He was the number one on what I call it, the 9 magnificent neurosurgeons. And all these people, you might have recognized few of them here, Kawazi in the front line, and Yoko Kato were there. And the same meeting, the Asian Congress, but they changed. They are not talking about the complex approaches. They're talking about less invasive approaches and brought us back in the sequence of these approaches to the two major powerhouse approaches, which is for the anterior is the frontal or subfrontal and terional approach, and the less trend with these complex approaches. Do we need them? There is a specific indication, but it was popularized that everything would be gone for the anterior fossa frontal orbitozygomatic. And the same happened to the posterior fossa. Back to the retrosigmoid approach is the major powerhouse approach that you have, again, put in indication many of the tumors from the posterior fossa. And of course, endoscopy added as a tool. We were laughing yesterday. We said, people come to you and say, I am an endoscopic surgeon. I told Professor Samii yesterday, then that means I am a CUSA surgeon. So you cannot tag yourself as a tool. These are tools are available, and that's what we learned from Professor Samii. He always said that he has the endoscope in most of the cases in the operating theater. He uses it whenever it's needed. It's no doubt is a very helpful tool to be used. That famous uh, major publication that became bestsellers, that book, The Art of War. It was written the 5 BC by Sun Tzu, who was not a military, but he established that book for the military. It was distributed as an educational material in most of the militaries in the old time and recent time, and became bestsellers in the recent years because it was applied to not only to military and war, and now we are unfortunately enjoying wars nowadays in different spots of the world, but it was applied in even in businesses and applied in any career development. And this is the quote too, we have to apply the art of work. And I quoted few sentences where we can apply it in the practice of neurosurgery. Study, plan, execute. These are one of the items in the art of war. It means for a neurosurgeon to rehearse ahead of time before his surgery and select the proper approach. You review your terrain, your anatomical regional anatomy, and you maneuver your enemy, which is the tumor, by tackle multi avenues and different front. Don't be stuck to one avenue. Cut supply on the enemy, which is the feeder to the tumor, and try to maintain the normal perfusion to the rest of the brain, and welcome allies. Help, it means a multidisciplinary approach, and be used anticipation principle to predict complication and to handle them, and they use different weapons. Multimodality in neurosurgery is very important. There are a few examples where you can use multimodality. So code 3, apply the principle of wabi-sabi. If people have not heard about this, this is a principle, actually a Buddhistic principle, and a colleague from Japan, when I asked them what is wabi-sabi, they said, oh, it's very difficult to declare and clarify. The summary of wabi-sabi principle is accept imperfection. We are not trying to say you do little, but you try to do what is best in your hand to the patients without damaging the patient. We all seek perfection, and this is the intention, but accept imperfection if you leave a little tumor on the nerves that each time you touch, and there is a drop in the signal of the facial impulse, you don't try to fulfill your ego and go after and end up having a facial palsy for a patient unless you are 100%, you will bring this patient to safe haven. The fourth principle is practice what is Leonardo da Vinci has put as a principle. Curiosity is the issue number one that you have in mind. This is where you initiate your innovation and and handle the brain as a whole. Don't forget about the rest, not only the tumor, but remember there is vascularity, perfusion to the brain, and this is part of a human system should be considered. So you look to the whole body. Code 5, this is where I quoted Professor Samii from the past years when the discussion endoscopy and microsurgery. And he summarized it in one statement. It doesn't matter what you are using, but perfection of microsurgical technique, you need it for both. When I see pulling rather than peeling in endoscopy, this makes me concerned about the outcome. It's not only the tool you are using, but what you are doing as a microsurgical technique. And in his statement, functional exposure should provide good functional outcome, no matter, because whatever you say, you used your outcome on this patient is what is count. And that's what the patient wants. Patient first. That's the code of Professor Samii. He has given us a lot of lessons. I will handle a few of them fast. The tailor simple approach, as I mentioned, it doesn't exclude complex approaches described by my speakers. There are indications for this, but should be very selective. But these are, as I said, the dogging horse approaches that you need, simple approach, and tailor it. You drill whenever it's needed and what is needed. You don't go across the board. You say, I will take the orbital rim for all cases to be better exposure. You compensate it by flattening of the orbital roof, by taking spheroid wings if it's needed. You open cistern. The manipulation, how you do it, this is what is counted as a microsurgical technique. One thing I learned very well, and I remember a case of Professor Samii operated in China. He showed it, I think, previous meeting, and a child where he has a huge tumor in the posterior fossa going everywhere. He just simply did a retrosigmoid approach, took that tumor completely out, documented with an intact patient. That was very impressive by single approach. When you learn the technique and you do it properly, the space you initiate by the tumor resection, it gives you a comfort zone to go further, to take the rest of that tumor from a different compartment of the brain. So use the space resected as a comfort zone. Hybrid use of endoscope. I don't say I use endoscope only or microscope. I use the microsurgical technique in both, and the endoscope I use it as an extended arm, extended visual arm to see some corners that I could not reach. And this is how it abandoned the complex approaches, because when you use the endoscope, it gives you an additional mile, an additional corner, blind corner that it will help you. And it was clearly shown by my previous speakers. Best example of simplicity.
2 minutes.
Yeah. Example is the transfemoral surgery, and many forgot about Griffith. Griffith, a humble neurosurgeon from Bristol, who described the direct approach to the sphenoid. That's what I'm using. And my colleague, Professor Farbush, who is at the INI, he has a vast experience. I think no matter you go ostium or rostrum as an approach, important is the target. And of course, use the tools, and whatever size of the tumor, you can use that resection. That's clock technique I have described earlier. So we took big lesions, and I used the transnasal direct approach, complemented with the endoscope to take any residual tumor. We took tumor like this in single stage without extension, and the same with that one, huge tumor. But as I said, the cavity of that tumor gives you space to go further. For Cushing, of course, I thought there is no need for endoscope, but it helps to see the medial wall of the cavernous sinus and the infradiaphragm and behind the stalk. So there are new indications now to go from below. Of course, there are many listed, but not all of them. Cystic craniopharyngioma, it can be managed from below, but it can be managed from above. We use the endoscope in either way. And this is, I use the endoscope from above. When I took the tumor to terional approach, some of the corner, I used the endoscope, and you see it was a nice picture of the carotid artery and the optic and the pituitary stalk. You see the residual tumor, you can take it out. I'm not going to show video because it seems time limited. Going from below, for sure not. For sure not. although they describe that you see the vascularity, but there are many concern. This convert craniotomy into craniectomy, and reconstruction is a major issue. Leak is a major issue. Simpson grading resection is a major issue. So please stick to the approach that has given you the best outcome. We went for this one enticed by the displacement of the basal artery and the midline. So it was a meningioma resected through transclival approach. I see the indication, but was rarely to get the tumor like this. And you see the expansion and the chordoma is another one. It's a purely midline. So I went in, got the histology, decomposed the tumor. See, it's almost complete resection, transclival approach. But for the anterior lateral, again, this approach, the frontal and the terional approach, give you access to all these lesions in the regions. And we kept the frontal orbitals occasionally for some complex aneurysm of the basal artery or cavernous sinus surgery. And opening the falciform ligament is an add-on to get the best outcome for visual surgery in that approach. This is examples. And you see the endoscopy give you a nice view, the stalk and the carotid artery and even the perforator.
Imad, can you?
Yeah. Just two slides.
Okay, go ahead quickly.
For the posterior fossa, I have modified this approach from the sitting approach. What applied in sitting, I'm using it here. I elevate the trunk of the patient in the lateral position in a place where the anesthetists were shaky to have a sitting position when I arrived to Saudi Arabia. But the same principle. I elevate and I rotate the head, and you see the dependency of the cerebellum away. And this is the typical approach of the supramiata approach described by Professor Samii, and I think the paper was written by Mario. And we took the principle. Yesterday, I saw a lot of videos. The amount of blood outside the tumor is much more than in tumor. If you have a blood outside the tumor, outside the capsule, it means you were not doing the right dissection of the arachnoid, which is the two forceps technique seen by Professor Samii with a lot of water and no coagulation. But the tumor like this sizable, I left something because this is the area where I have problem with the facial. I said it's better to keep a little bit, accept the wabi-sabi imperfection, because then they'll have alternative for this one.